So I'm just going to pull this down.
Oh, okay.
It's very short. So welcome to the 7th Monitoring and Evaluation Roundtable on Scaling Up Social Programs, hosted by the Center for Learning, Evaluation, and Results South Asia Center, also known as CLEAR, based at JPAL South Asia. CLEAR provides technical expertise on monitoring and evaluation, strengthens the capacity of grassroots organizations in M&E, and builds demand for credible evaluations from policymakers. It is our hope that through these roundtables, we can bring together many important stakeholders to discuss new ideas and encourage future collaboration. Our past roundtables have focused on the value of evaluations and systematic reviews, and today we are very excited to present a roundtable that will offer an important perspective on the link between evaluations and scale-up. This discussion will offer insight into how we can take programs and policies that have been shown to work and find ways to ensure that they benefit many, many more people. This event is being webcast and will be available on the website a few days after the roundtable is finished. So today we're very privileged to have our guest speaker, Dr. Richard Kohl, who has extensive experience in the field, including over 6 years of experience working specifically here in India. So Dr. Richard Kohl is currently founder and principal of the Center for Large-Scale Social Change, whose mission is to support the scaling up and high-impact innovations worldwide. Richard has worked on scaling projects and programs in health, education, rural poverty, and livelihood training in over 30 countries, including over 6 years commuting from the US to India to support scaling up of NGO-run programs in maternal and reproductive health. Dr. Kohl has taught scaling up at the University of California at Berkeley, Harvard, and Portland State University, among many others. And he holds a PhD in economics from the University of California at Berkeley. So Dr. Kohl is happy to take your questions throughout his presentation. And just to let you know, each of you have microphones at your table. So if you would like to ask a question, you can turn on the microphone to speak. And now I will turn it over to Dr. Kohl.
Thanks. Thanks, Mara. Is the mic okay? Everybody can hear? Great. So I'm really happy to be here, and I want to thank JPAL and CLEAR South Asia for inviting me. I haven't been in India in a couple of years, so it's nice to be back, and thank you all for coming bright and early on a Monday morning. I'm mostly going to talk today about scaling up and how you do it and some of the challenges you face, and not so much about evaluation. I'm going to assume that the programs we're talking about have some sort of evidence, or at least promising, if not proven evidence, that they work. But if during the course of our talk today you want to talk about how do you do evaluation or monitoring, either of a pilot to prepare it for scaling up, or during the scaling up phase, I'm happy to answer questions and discuss that as well. The principal thing I'd like you to get out of my talk today is there's no one way to scale up. I think just in the time we had before we got started, and I talked to a few of you, some of you work with NGOs, some of you work with bilateral donors, some of you are working with the government, and some of you are trying to scale up through the private sector, and those are all viable mechanisms of scaling up. They each have their strengths and weaknesses, and one of the things we'll try to talk about today in the limited time we have is when does one choice or menu of the various choices make more sense for scaling up than others? And the short answer to that question, well, it's not really a short answer, even the short answer is not such a short answer, is that it really depends on both the innovation or the service or product you're providing itself, which will have certain characteristics, the population you're trying to serve, and the social context in which it works, or which it lives and works, and last but not least, the institutional capabilities of those different options. That usually the private sector or the government or the NGO sector have different strengths and weaknesses, and which when you match them with the intervention itself and the population and location, sometimes they're a good fit and sometimes they're not a good fit. So it's actually figuring out the appropriate scaling up strategy for what you're trying to do is actually a case of putting all the pieces of the puzzle together in a way that fits the best. So what I'm going to try to do today is to, first of all, go through a few definitions. So we're all talking about the same thing. I think one of the reasons that scaling up can often be challenging is that people use it to mean different things. And I'll talk about what at least for the course of the next, when you get to give the talk, you get to define how it means, right? But I'm also open to discussing with you different definitions if that proves to be important. And so once we get through some definitions, then I'll talk about what's the normal sequence or series of stages or phases that scaling up goes through. And then last but not least, how do we make those choices about which options we choose at each phase. Even though I'm going to give the talk, and particularly the talk about the phases of scaling up in a linear fashion, having done scaling up many, many times, I can assure you that I've never seen a case where scaling up actually happens that way. That often you do something, and then you go to something else, and then you actually end up going back to the first thing because it's very much an iterative process. And so I don't want you to come away that it's 1, 2, 3, 4, 5, because it just doesn't work that way in practice. I think Einstein said, and it's one of my favorite, actually either it's Einstein or it's a Yiddish saying, which for those of you who don't know is a mix of Hebrew and German, but the saying is that man plans, God laughs. And I think that saying is particularly appropriate in the context of scaling up. So to get started with some slides, the reason I think we're all here is because one of the things we've discovered, particularly donor agencies, but not only donors, is that scaling up doesn't happen spontaneously, or it rarely happens spontaneously. For every case of microfinance, which just seems to spread like wildfire, and I don't think we should underestimate the amount of work that people like Mohammed Yunus and others did to get that to go to scale, there are probably hundreds, if not thousands, of proven successful small-scale interventions that never go anywhere. And I think for many years, whether it was implementers or funders, acted on the assumption that if it worked, if people heard about it, and it had some decent evidence, that people would come and say, this is great, we want to do it too, and things would go to scale up spontaneously. For those of you who are in graduate school or thinking about graduate school or who have friends in graduate school, a really good dissertation would actually be to document how many of those wonderful programs are sitting around at small scale that never go anywhere, because there was actually no evidence about that. But my own personal anecdotal experience is I would say somewhere between 85 to 90% do not go to scale. And there's no particular reason for that. It's not because they're not good programs or they're too expensive or their evidence isn't good. It's just luck of the draw. Okay? One of the reasons I'm very happy to be speaking today, hosted by J-Pal and Claire, is because J-Pal and Claire are taking what I consider to be a very important first step in moving the scaling up agenda along, which is trying to raise the level of evidence so that at least we know that we are scaling up really good things that are proven effective, and so that policymakers or funders can make decisions that are highly informed. But as important as the work in terms of raising the bar on evidence and evaluation quality is, I think it's necessary, but it's far from sufficient, and that's what I'm going to talk about today. And I just want to say that I know some of you are from USAID and other donors. There is now a groundswell among donors to really get serious about scaling up. I've been working for UNDP, UNICEF, UNFPA. The World Bank now has a unit, the Agricultural Research and Rural Development Unit, that has developing its own models and templates for scaling up. And also GIZ is taking this quite seriously. So this is now the order of the day. It's no longer going to be the case that you can get away with, yes, we ran this little program in 3 blocks for 5 years. It reached 200,000 people, and now we're all happy. We don't have enough resources to continue to do that. There are too many people who need the programs that many of you are implementing, and small scale simply isn't cutting it. So let's move right along. I'm not going to share with you the experience that I've had working in scaling up. You can read the slide yourself, but worked with a lot of programs in India, mostly NGO run, but also a lot of other countries. And we could talk about that later. As I said, we're going to go through some definitions. Then we'll talk about the stages and steps and tasks. And I'll try, if I have time, to give you some applications of this, so it just won't be sort of this theoretical lecture, because that's not my point. My point here is to give you some how-to tools about how do you actually do scaling up. Okay? So if we get to concepts and definitions, one of the nice things about giving lectures is that or talks or workshops or seminars, roundtables, this is a roundtable, is there always seems to be a handy water bottle. And the reason I like the water bottle is because we all do capacity building, but actually capacity building is the wrong word to use for what we do. What we're actually doing is capability building. We're actually teaching people how to do things, which increases their organizational capabilities or their individual capabilities, but we're not actually increasing their capacity. Okay, so for some reason, again, those of you who need a master's in English etymology, there's a great research topic. But if we ask what the capacity of this is, what would you tell me? It's a liter, right? Okay, the capability of this is it holds water. Okay? And the reason I want to make that distinction is because in the case of scaling up, the distinction between capacity and capability is important because we need to have both. Right? If we wanted to scale this up, we would want to scale this up to maybe 5 liters, so we need to increase its capacity in the sense of quantity, but we also want to retain its capability of holding water or being waterproof. Yeah? And one of the biggest challenges in scaling up is doing both. Is that for scaling up, you need both capability and capacity. And as I'm sure many of you are facing this challenge, if you're a small NGO, you know how to implement your program or your innovation, so you have capability, but do you have the capacity to reach millions? And the answer is usually no. The flip side of that is often the case of the government, where the government's education system or health system or ICDS program can reach millions of people, but what kind of capability? Does it really have the capability to deliver the program with quality and impact? So the conundrum, or one of the principal challenges, is that trade-off between capability and capacity. Is that clear? No? Okay. So at least for the next few hours, I'm going to ask you to use capability and capacity in the way I've just defined it, and then you can go back to doing it the way you normally do it in your office. Okay? So there's 2 types. I'm going to use the sense of scaling up in 2 ways. One is expanding the model or intervention itself. And by the way, I'm going to use the word model, intervention, innovation interchangeably. Okay? So again, if you're a stickler for definitions, excuse me on that one. But sometimes about scaling up the model. So for example, we have with us today some people from Micronutrient, what is it? Initiative, thank you. Micronutrient Initiative, which among other things is trying to use micronutrients like iron and folic acid to improve maternal and child health. But they might actually not just, and they may be working in, let's say, a certain number of districts or states in India or Bangladesh or Nepal. Now, they could scale up to more districts, but they could also add more micronutrients, right? So that would be a case of scaling up the model as opposed to scaling up its reach. Okay? The alternative, which is I think what most of us think about, is scaling up the reach, going to more places. And I like to disaggregate that to, does this have a laser pointer? It does have a laser pointer. How exciting. Okay, so it could be demographics. So for example, Micronutrient Initiative might first initially target 0 to 3. But then they discover that actually there's a benefit, and so we're going to expand to 0 to 5. So they're not going to more places, they're staying in the same place but changing the demographic, the definition of who the beneficiaries are. Or they might go to more places, more districts, more cities, more states, or they might stay in the same place with the same demographic 0 to 3, but they might say, right now we're only reaching 50% of the children who need this. We want to go to maybe not 100%, but 99%. Okay? So all 3 of those are viable definitions of scaling up. So as you're thinking, as I'm talking, one of the things I want you to be thinking about is, what does scale mean to you? Is it more people? Is it more places? Is it different demographic categories? Is it higher coverage, or is it all of the above? And what's the model you're going to be using? Is it just iron and folic acid, or is it something else? Are you going to be adding things? Or conversely, you may have a very complicated model that has multiple components. In other words, for example, I'm not picking on Micronutrient Initiative, but they may have started out with 10 different micronutrients and discovered that the supply chain challenges were just too complicated, and that they actually went from 10 to 5 because they could have a bigger impact with 5 for the money. Okay? So In a sense, we're talking about scaling up, but in some cases, particularly for the model, we might want to think about scaling down the model to scale up the reach. So should I repeat that? Scale down the model to scale up the reach? Because remember the previous slide, or 2 slides ago, I talked about the trade-off between capacity and capability. If we have organizations that have lots of capacity but weak capability, the simpler the model, the easier it is for them to implement at scale. Making sense? Yeah? Okay. So the definition that we're going to use today for scaling up includes both reach and scope. So I'm using scope here to mean what's in the model. And it's the process of sustainably increasing the reach and/or scope of a promising or proven program with fidelity and quality, thereby retaining some or all of its demonstrated positive impact. So I want to take this apart a little bit because I want to make sure we're on the same page. So first of all, scaling up is a process. Okay, it doesn't happen just bang, bang. And I'm using in the definition of scaling up sustainability. So I'm not interested in the fact that we go from 1 district to 3 states over a 3-year period, and then the USAID money runs out and the program disappears. Okay? I want to know what happens when the USAID or the GIZ or the World Bank or the Goldman Sachs Foundation money disappears. Do you still have a program? Because if you don't, then I think, well, I'm not going to disrespect the hundreds of thousands of people that may have been reached during the project period, but I think if we don't want real change, we need it to be at least permanent and lasting. Okay? Similarly, I think we need to be scaling up a promising or proven program because there's limited resources out there. We don't want to scale something up that we don't know that works. And last but not least, one of the most common problems in scaling up is that we get scale, but we lose impact. Right? And so the reason I have this whole second half of the definition, fidelity and quality, fidelity means, I think from the Latin, that it's true to its origins. Okay? So that means that we're scaling up roughly the same model that had impact at small scale at large scale. Because otherwise, if we change the model, or if we dilute the model, which is quite common, then we lose the impact. And so therefore, if we do it with fidelity and quality, we should be retaining some or all of its demonstrated positive impact. And so again, one of the challenges I'm going to get you to think about for the next time, for this morning that we spend together is, what's the trade-off for you between fidelity and quality and scale? In other words, what I'm asking is, as we grow the model, we're likely to lose some of the quality. How much do we need to retain? And what are the key things to retain in order to get that positive impact? Because it seems to me that if we can go from the perfect model that has 100% effectiveness for just a few districts, and we can get to millions with 80%, that's a pretty reasonable trade-off. But if we're starting to get down to 20-30% effectiveness, we don't want that. So where is that sweet spot of that mix between retaining fidelity and the capability to implement with fidelity and quality and scale? Okay? Okay. So the phases of scaling commonly have a model or an intervention. And one of the things I want you to think about, by the way, I tend to be repetitive, but that's because I think I was raised in nutrition. If you don't hear things like at least 3 times, you forget them. So I'll probably say everything at least 3 times. So excuse me if you got it the first time. But a model for me has both a intervention and an implementation or process. And in some cases, the intervention is really important. And in some cases, the implementation process is important. And in some cases, it's both. So when you think about technical interventions, like the folic acid, that's just, that's the magic bullet. It's a little pill, okay? But the key question is, how do you deliver that, okay? Or if it's an educational intervention, like we have 2 groups here and maybe more, both ARC and Room to Read, which are delivering a curriculum, but it's not just the curriculum they deliver, it's how is that taught? Who delivers it? Is it delivered by teachers? Is it delivered by parents? Is it delivered by facilitators? And there's a tendency to focus only on the curriculum, on the technical content or the pill, and not the process by which it's delivered. And then that's where you get quality and fidelity to break down because of the focus on quantity and not process. So one of the, I'll probably say this 1,000 times today, one of the net takeaways I want, the top 10 lessons, I'm going to say 10 because I usually say 3 or 4 and it ends up being 10, is focus on fidelity of process is really important. I'll give you another example. I can't tell you how many times I'll say, somebody say, so tell me about your intervention. Well, we work with the panchayat in this village and we work with girls of 10 to 15 years old and we teach them about literacy. Okay, or about sexual harassment or something like that. And I said, whoa, whoa, whoa. How did you just show up in this village and you get all the 10 to 14-year-old girls and you start working? Oh, no, 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 no. First, we go talk to the State Department of Health and the Department of Women and Youth, Women and Children, excuse me. Then we talk with the district collector and the district health officers. Then we talk with the Panchayat Raj. And then we talk with the parents. And finally, we get to that. To working with the girls themselves. And I said, well, how long does that take? Oh, often 1.5 years or 2. So if you don't do all that other stuff, okay, can you actually deliver the content? No. So that process is part of your model as whatever you're teaching or whatever pill you're delivering, whatever service you're providing, right? And most of the time, people don't document that, and then they don't understand why the model doesn't work as well at scale because parts of the process end up being missing. It's kind of like asking people who are, if I can use this analogy, it's like asking the fish, what's the nature of the water you swim in? Yeah? They don't know because they do it all the time. Okay? So then there's the model itself, and we need evidence, which I'm not going to talk too much about. We've already talked about the fact that sometimes you need to simplify the model or to scale down to scale up. Yeah? That's simplification. Documentation, so I've talked about the importance of process. And finally, cost. Okay? A few years ago, DFID asked myself and a colleague to do a survey of maternal and child health interventions in India that were being piloted at small scale that might potentially have some promise for scaling up. We were able to identify 150 ones that were being piloted at small scale. Guess how many had cost data? When I say cost data, I mean more than the project has gotten a $5 million grant from USAID over 4 years to deliver to 200,000 people. I mean slightly disaggregated like that. We actually tracked how much it cost to deliver this, excluding the overhead, the 20% technical assistance from the United States. But the question I'm asking is if the government in India came to you and said, we want to do this in 50 places, and here's 50 crore. Could you tell me how many people you could reach? What's the unit cost per beneficiary? You know how many out of the 150 had data? 5. Okay. So ask yourself, if we're going to go to scale, do we know what the unit cost is? Or even more importantly, if we had a 10-component model and we were going to simplify it to 5, because the budget that we have is 1,000 rupees per beneficiary, but the cost at small scale was 2,000 rupees, so we have to get it in half. How are we going to cut it in half? Which pieces should we cut? Okay, do we have data that we can make an informed decision on that? If we don't have that data, then we have a problem. Okay? The third part is then a strategy, and we'll spend a fair bit of time on this today, I hope, which is where are we going to scale it up? So that's, remember the previous slides. Is it demographic? Is it geographic? Is it coverage? What are we going to scale up? What version of the model, intervention and implementation process are we using? Are we going to simplify it or not? And how and who? So this is what we started to talk about earlier. Are we going to go through the government? Are we going to go through the private sector? Are we going to go through NGOs or maybe all of the above? Okay? And you're starting to see that those pieces have to fit together. What's the scale? What version of the model? And who's going to do it? And who's going to pay for it? Okay? And the version, well, I'll come back to this later. Now, once we've figured out particularly the how and the who, we then have to get those people or organizations to agree. Okay? I'm giving this talk today on the assumption that a lot of you are thinking of scaling up through the government, so I use the word advocacy. But for my money, if you're going to scale up through the private sector and you want to call it marketing, that's fine too. It's just a different approach. It's just getting other people to agree to to play their role. If they're going to be the implementer, who's going to implement? If their government's going to approve it, who's going to sanction it? If somebody's going to fund it, why would they agree? So there needs to be advocacy to make all that to happen. Okay? Okay. Once we have the strategy, we know what model, and I hope you can see, by the way, why this starts to be iterative. So what happens if we get down here and we can't convince some of these people to do it? Then we may need to change the model or need to change our strategy. So we're going to be constantly moving between which version of the model, what evidence or simplification or cost is it, who's going to do it, and who are we convincing. Does that make sense? It's not a cookie-cutter process. It's not a linear process. We then need to do, notice what capacity, capability building, and also the enabling environment. Okay? And I'll give examples of this later, but basically, we may have the case where we have organizations that have the capacity to reach the populations we want, but don't know how to do it, so we have to build their capability, right? Or conversely, we have organizations that know how to do it, but they can't reach, they're not big enough, and so we're going to grow the organizations, and I would call that capacity building. See the distinction? Capability is teaching them how to do it. Capacity is getting them to the capacity to do it in more places. We might want to do one, we might want to do the other, we might want to do both. And then last but not least, the enabling environment is we may need to change laws, regulations, and other things to get this to work. Some of you are old enough to remember that back in the 90s, one of the big things in public health was family planning. And then all the money disappeared in family planning because it got replaced by HIV. So everybody I knew who was working on family planning said, how can we scale up? There's no money for this. And I said, well, don't you teach about HIV? And they said, yes. I said, so you just have to rebrand yourself. You're an HIV program, you're not a family planning program. So we were actually doing this in East Africa, in Kenya and Tanzania, but one of the problems was they couldn't get supplies of condoms from the HIV supply chain because they couldn't actually get the requisition form. And it took 6 months to change the regulations to allow the family planning clinics to be able to requisition through the HIV supply chain. So this is what I mean about changing the enabling environment. You may think this is trivial, but I cannot tell you how many times I've seen scaling up get stuck in this kind of stuff. Whoops. Then we need to monitor and feedback for quality, fidelity, and adaptation. So here's another concept I'd like you to come away with, which is the trade-off between fidelity and adaptation. Okay? So if we go back, right, implicit in wherever this model was piloted, is piloted in a certain place, in a certain social context, certain infrastructure, certain institutions. That place, that context, that social structure may be the same or different about where we're going to go at scale. Okay? If it's different, we may need to adapt the model to work effectively in that new place. So we now have a tension between quality and fidelity and adaptation. Okay? And I could talk more about that, but when do we want to keep it the same and when do we want to change it, and how do we retain impact in changing it? For those of you who are monitoring and evaluation people, this is the question of external validity. We prove internal validity is that it works. External validity is where does it work? And I use where, in this case, in two senses, not sentences. Senses. One is in what types of delivery mechanisms and in what social or geographic contexts. Okay? It worked when it was delivered by an NGO. Will it work if it's delivered by the government? It worked if it was in rural Rajasthan. Will it work in an urban slum in Mumbai? Okay? So that's the external validity question we have to get at. And last but not least, sustainability. So what do I mean by sustainability? Well, you remember in our definition, we wanted something that didn't disappear. So the first thing we have to worry about is political sustainability, especially if we're working with the government, but even if we're not, even if we're working with the private sector, NGOs. Remember, a key to this is somebody had to agree to do it. They had to agree to fund it. Okay? Well, particularly, I wouldn't say particularly actually, in most countries, and I certainly think India is no exception to this, or South Asia, political decisions are highly individualized. It actually makes a difference who the Secretary of Health and Family Welfare is. And if that person changes, they may have liked your program, but what happens when the next secretary comes in, or the next district collector, or at the state level? And in a complicated place like this, where we have the national level, the state level, the district level, the block, the village, all those people are always changing. How do we sustain political support to do this as those actors change? And even if it's an NGO or if it's a private sector, what if the CEO changes? What if the executive director changes or the head of maternal health for this NGO changes? If those players change, how do we retain political support and participation of those organizations? Okay? So building in a political sustainability strategy is as important as actually delivering the model well at scale. The second part is financial. We already talked about that. Often donors will give money for either the pilot or, if you're really lucky, the going to scale, but they won't give money for implementing at scale. They don't have that kind. They claim they don't have that kind of money. So if their money's not going to come from them, where's it going to come from? So if you don't have financial sustainability, you got nothing. And last but not least, institutional sustainability. Anybody know does everybody know what an A&M is? A&M, auxiliary nurse midwife. It's the bottom line, the front line of the health system. Okay. You know what the turnover in A&Ms is over 5 years? It's about 50%. Okay. Because A&Ms tend to be young women in their 20s. They get married, they move to a different village, and they leave their position. So a classic thing that happens in scaling up is DFID will want to scale up maternal and child health. We'll train 50,000 A&Ms on how to do it. DFID gives them money to do it. Then the DFID money goes away. The government pays for the A&M salaries, but there's no money for 3 years later when 10,000 of those A&Ms are no longer there to train the new A&Ms. So how can we create institutional sustainability so as we get turnover in human resources or breakdown, or the schools need to be maintained, or the health clinics need to be maintained, etc., so that the intervention is sustainable over time, institutionally. So we need political support, we need money, and we need the human resources and the infrastructure to be sustained, or else we don't have scaling up. So let me just stop for a second and see if there are any questions or comments, because I've been talking for about a half an hour, and either you're all fast asleep because it's Monday morning, or I've completely confused all of you. Any questions so far? No? So far, so good? Okay, so we can have a quiz now, and you'll all... No. All right. So I'll keep going then. All right. So I've already said I'm going to present this in a linear fashion. I don't think that anything I'm saying is other than common sense. What I hope you'll take out of this is that I've presented the common sense in a systematic fashion that allows you to use it to apply it to scaling up. Okay? I'm not going to have a chance to go through all the tools you can use to do this, but I have those tools and would be happy to work with your organizations one-on-one to apply them. So I'm just going to give you the overview. So you remember the key question of scaling up is what is being scaled up? What's the model? Intervention plus process. Where? What are the goals? Should it be scaled up, which I'm not going to talk about much today? And the how and the who. So let's take these one at a time. And I usually use this kind of a framework, which is, first of all, what is the model? Whoops. What is the model? What are the goals? Is it scalable, and how can we improve scalability? Creating a strategy and reconciling the model, the vision, the method, putting the pieces together, basically. So in the time I have remaining, let me take these one at a time. If we get to it, I'll have a chance to talk about the advocacy and the monitoring and the capacity and capability building, but I'm not sure I'm going to get there this morning. So stay tuned. I know some of you are coming to the long version on Wednesday, Thursday, and Friday, and you'll get all of that. Okay? So the first question is, what is the it that needs to be reproduced at large scale? What is the model? And let me jump back and forth here. So remember I talked about this business of like going into the village and getting permission? So that's a key part, right? Here are some of the other things that people don't think about, which is, oh yes, we decided to implement this in 5 districts in, pick a state, Uttarakhand, and in each one we have a local NGO. What did you do to that local NGO to get them to be able, right? That capacity building or capability building is as part of the model at all. Then we have the technical elements, which is, let's say it's okay, we're teaching English language through phonics, or we're teaching literacy, okay, and here's what we teach. So we have the curriculum, that's the technical, that's the what, but how do we teach it? I do a lot of work in scaling up education, particularly early childhood development. And one of the key innovations that most cutting-edge organizations are using is a shift from teacher-centered pedagogy to child-centered pedagogy. Okay? Most people who are over 30 in most countries if they have a professional degree as a teacher, learned teacher-centered pedagogy. And getting them to shift from teacher-centered to child-centered is very difficult. Yet my experience, and I think some of us could share from that, is that the impact of this model is as the curriculum it is with a teacher-centered model, and you get half the results. So we want to make sure that we know the tacit knowledge as well as the technical, the what as well as the how. Yeah? Or the how as well as the what? Everybody with me? Yeah? Okay. And finally, one of the key questions I always ask, maybe it's because I think it's the one thing I learned in graduate school in economics, is about incentives. Why do people do this? Okay. And one of the things I love is we piloted this in this state, in 2 districts, and now every teacher in the state is going to do it. Really? Because they were sitting around most of the day with nothing else to do, and they're eager for someone to come and give them extra work. Okay? Are they going to do it because you're paying them extra? Are you going to do it because they find intrinsic satisfaction out of seeing their kids be able to speak English? They get positive feedback from parents. They win T-shirts. They get awards. What's the motivation, particularly for frontline supervisors, but also principals, if it's a school, to adopt this innovation? And if we don't replicate the incentives, you can replicate the what and the how until you're blue in the face and you'll get nowhere. Okay? So often things like monitoring, supervision, and other types of incentives are extremely important for success. Okay? So you're now starting to see what am I talking about what's the model. It's not just this is the core, this is the intervention, but it's all the stuff that comes before and afterwards that is equally important. And a lot of this doesn't get replicated, and that's why scaling up loses impact at scale. All right? Who's keeping time for me? And how am I doing? Could you be more explicit?
Okay,
like how?
50 more minutes.
50?
Yeah, including the Q&A session.
Oh, okay, fine. All right. So what I'm going to do then is I am going to try to give some examples, but I want to go back to this slide, which is what is the social context in which the model was piloted? Okay, so for me, part of documenting the model is not only documenting the process, the tacit knowledge, the monitoring, and the incentives, but also where was it implemented. I bet some of you are familiar with this thing that you love. You lie awake nights dreaming of logical frameworks, right? How many people here, you won't admit it publicly. How many here dream of logical frameworks? There are at least one. Okay, we have a brave soul. Okay. So one of the tricky things about logical frameworks that you've all known to grow and love is that people forget the last column, which, if you may remember, is assumptions. Okay? So let's give a very simple assumption. Okay? Very simple model. We want to reduce population growth in India. The model is we increase the supply of family planning commodities to primary health clinics. Okay? And we show at small scale that works. The key assumption would be that people, particularly women in most cases, go to the clinics and get them. Well, women's rights to freedom of movement and make decisions about family planning are not uniform across India. Right? What somebody may have the power to do in Tamil Nadu or Kerala may be different from Maharashtra and is certainly going to be different from Rajasthan or Bihar. Okay? And particularly because a lot of the social interventions that we are interested in scaling up involve women. Gender empowerment and gender rights are absolutely critical contextual question for scaling up. If we don't document that and make sure how it's the same or different where we go, we will often have problem delivering. Okay? Similarly, one of the big differences between moving from urban to rural is access. It's one thing to expect somebody to walk for 20, 30 minutes to a school or a clinic or a service provider to get access. It's another thing when there are no buses, there are no trains, there are no tuk-tuks or three-wheelers, and we're in a rural area, 2 hours may be too far. So questions of women's rights, women's ability, questions of transportation and accessibility, of providers, and all these things are just a few of the social context questions that we have to document, because those are key assumptions that may have made the model work or not. Can anybody come up, since I'm tired of hearing my own voice, with a couple others, maybe applicable to your own models? Can I get a a volunteer? Yeah, go ahead.
Well, one of the things.
I bet you they want you to use the mic because they're taping it.
Okay, and I'm Cassie from CRS. So I was just thinking about disaster risk reduction programs and flood preparedness, and building of raised tube wells has been really effective in giving people access to clean water during floods, but with the idea that government would take it up. So in terms of social context, I would say, well, it would totally depend on the normal access to drinking water. So that's an assumption that people use the tube wells and that whatever other existing water facilities would be flooded during floods. I mean, you would have to...
Right, and to extend your example even further, there might be certain parts of the country where tube wells are relatively inexpensive to drill because the water table is fairly close to the surface, but there might be other places where you have to drill quite deep and it becomes simply financially infeasible to do that. So when I use the word social context, I am focusing on social, but things like geology, infrastructure, climate also can have an impact here. Okay? The other piece that we need to document is, remember one of the questions we're going to ask in our strategy, let me go back here, whoops, is who is going to do this? Who's going to scale this up? Who's going to implement at scale? Okay. Well, we can't figure out who unless we know what it takes to do the model. So one of the things we want is that are necessary to implement that. Okay? What do you need to know how to do that? And you might be surprised. Okay? For example, well, I'll go right to my example. So I worked several years ago on scaling up something that is now going pretty much national in India called, home-based neonatal care, which was originated, by the Search Health ashram, which is in rural Maharashtra. And it was basically designed to lower neonatal mortality. And what they did is they selected and trained village women principally to analyze the 6 or 7 leading causes of infant death and then to treat it. And they used village health workers, women with a 10th grade education. They did have incentives. There was performance-based pay. So they actually monitored quality. If they did the diagnosis wrong, they didn't make as much money. And they were regularly supervised. And interestingly enough, there was a lot of community sensitization, particularly with traditional birth attendants, because historically introducing trained midwives or this type of assistant, these village health workers, often the TBAs find this very threatening, and that creates a problem in implementation. Okay? Now, I want to give you an example. So the key concept was focus on newborns. It was a shift from hospitals to home. It was empowering the community health workers of VHWs. And this is what a community health worker looked like. That's her kit. And they would go and visit each baby. What do you think in Maharashtra was a key social context variable that made this work? For those of you who know India. I bet most of you know India. Yeah. The caste of the women didn't make a difference. Because at least in this part of India, low caste women were welcome to go into high caste women's homes and vice versa. When this was moved north, that became problematic. Okay? So that was an example of documenting the invisible assumptions column in your log frame that needs to be done. Okay? So I would think that most of you who are Indian, who have worked here for a while, things like caste, class, community might be variables, again, that you want to look at. Might not make any difference at all, but that's what we want to look at. Okay? What's going on here? Okay. So when this intervention was begun, you can see that infant mortality rates in this area, they actually started just working on pneumonia, and it was about 120. Then they created home-based newborn care in 1995, and by 5 or 6 years later, the infant mortality rate had dropped from about 80 to under 40. Okay? This was not done as a randomized controlled trial. It was done with control groups. and the evidence was quite significant. It was published in The Lancet. Okay. Now, what do you take away from this graph? Well, I hate when teachers or people leading already know the answer and they expect you to guess. So I won't make you guess. Okay. What I want you to take away is the time frame here. That basically this was innovated and piloted over almost 15 years. Okay. And the Lancet publications occurred in the late 90s. Okay. I was asked to help start scaling this up in the early 2000s when this had already been integrated, declared as a best practice by the Planning Commission. And it was integrated into, what was it? I'm losing my mind. RCH1 or RCH2, the Reproductive and Child Health Programs. So policy had been recognized. This had been recognized by policy, and this went nowhere. Does anybody have any experience of that, where a program is adopted in policy but never gets scaled up in practice on the ground? Okay, so one of the things I want us to pay attention to is that policy adoption is maybe necessary but far from sufficient. So let's talk about setting goals. We now have the model, which is this home-based neonatal care model. What reach, what impact, what sustainability, what coverage, and what time frame? So this is the second thing we need to figure out if we're going to scale up. Okay. Now, if we apply this to the HBNC model, they believe that this was applicable to 500,000 villages. I'd say that's scale. Yeah? Okay. They wanted to replicate the community-based approach using village health workers. They also were using a rights-based approach and gender equity, empowerment, and respect. They felt, so here's a question about tacit knowledge and process, that the fact that the village health workers were empowered was key to the success of the program, that they were given dignity and respect by the community. And actually, this was also the primary incentive. It wasn't that they made so much money, but they actually saved lives, and their peer women in the communities actually respected them. So it turned out that the key incentive was the respect of their peers. Right? They wanted the same drop in neonatal mortality rates and infant mortality rates, which was 60 and 75%. And they wanted to reach particularly marginalized communities of scheduled tribes and scheduled castes, and any place where institutional care was not available, ultimately universal. So notice, this is important for the story later, that the key here is that this is going to scale in places where there are not access to hospitals and clinics. Okay? And they wanted it rolled out in a phased manner. Okay? So, let's take a look before we go ahead with our story and say, is this a scalable model? And if not, what can be done to make it scalable? So here are the criteria that I use to scale, to decide whether a model is scalable. First of all, is it credible? Now, credibility has two components. One is hard evidence, the kind that JPAL and CLEAR advocate, which is randomized controlled trials. But unfortunately, in the real world, that's necessary, but also endorsements make a difference. If you have a prominent physician, a prominent educator, a professor, and a Amartya Sen who says this is a really good model, that can count for as much as the fact that we have hard evidence of a 20% decrease in infant mortality. Okay? Is it observable? How many times have you seen someone come and visit a program and see it and make a decision that it was a good thing, independent of whatever hard data you have? Okay? This is what I call, does everybody know what heifer is? Heifer. Heifer is an NGO that basically gets you to give money to buy an animal like a cow or a sheep for okay? So I think that their thing works because you can see it. This little villager has a cow and their kids are drinking the milk from the cow. Okay? Easier to scale that up than an empowered woman. It's not sometimes so easy to see an empowered woman. Okay? Or, you scale up iron and folic acid because you can see the difference in how that affects babies and young children. So is it observable? Is it relevant? Just because it works, if you're selling a solution to something that people don't think is a problem, it's very difficult to scale up. Okay? I was once asked to help scale up some programs that were working on lesbian and gay rights in India. Okay? It's not that I don't think that's an important issue, but it's not clear that the policy environment or the public environment for India right now is particularly receptive to that issue. So if people don't think that the problem that you're trying to solve is a problem that you can have a great solution, it won't go anywhere. That's like what we talked about before about HIV versus family planning. Okay? There are certain things, I think some of you have been around long enough to know that things go in cycles. There's what I call a policy window where an issue is trendy for 5 or 10 years. For 5 years, it's sanitation. For the next 5 years, it's drinking water. For the next 5 years, it's women's rights. Domestic violence against women has been going on for decades in India, but all of a sudden, because of the highly publicized rapes, now we're going to do something about it. Okay? So you may have had a great model to stop domestic violence 15 years ago that went nowhere in terms of scaling up, and now is your time. Okay? Now, that's not to say if the policy window isn't open, you can't do something, but it means you basically have to work to create that policy window. Okay? If there isn't demand, you have to create the demand. You just can't have supply of a policy solution. Okay? And especially for those of you who are donors in the room, I think there's a tendency to either only fund solutions and think that advocacy happens by itself, or only fund advocacy and think the solutions happen by themselves, or you fund both but they're separate institutions. Right? Like, again, I don't know how many of you work in health, but as you can tell, I've worked a lot in health. So there's 2 big institutions in India, Population Council and the International Center for ICRW, Rights of Women. What does it stand? Research on Women, thank you, that do a lot of research and publish great stuff, but they actually don't implement programs on the ground most of the time. And then you have all these NGOs that are out there with great solutions, but they don't have the kind of credibility and research potential that Pop Council and ICRW have. And getting those to work together is not so easy. So thinking about how do you align the solution with the policy priorities is a key question. Does it have a clear advantage over existing policy programs and practices? Remember, we started with just evidence. Then I asked you I wanted evidence of cost or cost effectiveness. Now I want comparative cost effectiveness. And actually, that's a pretty high bar. We're not there yet in most cases. But if we really want to move towards scaling up, moving towards that type of evidence, I think is our long-term goal. Okay? 5th, who are the winners and losers? I think we all have a naive notion that because we're doing something that's going to benefit a lot of people, the poor, women, children, etc., that everybody would support this. That's often not the case. So I'll come back to this one. Well, let's just jump right in. Who do you think the losers were for scaling up home-based neonatal care? Who opposed this? I'll give you a hint. One of the key parts of HBNC that helped reduce infant mortality was that the leading cause of death of infants is what's called sepsis, which is the systemic infection, and you need to give an injection of antibiotics pretty much immediately, which works. It's not that complicated, and it's a fairly standard antibiotic. They were using what's called gentamicin. Who would object to that? Private sector? What? Who in the private sector? Who did you say? Pharmaceuticals. Well, not so much pharmaceuticals. It was the doctors. Okay, physicians. If you're in rural India and you go to I think the common expression is a quack. I think the less common, what's the correct expression? Rural medical practitioner. Rural medical practitioner. Thank you. Okay, and you don't know, you're an ignorant person and you don't know anything about medicine. How do you know you got value for your money? They give you an injection. It could be saline solution. But that's how, so now all of a sudden we have village health workers giving injections. The Indian Medical Association was extremely upset. Not that any of them actually work with any of these populations, because they're all based in megacities, but it undermined their power, their prestige, and potentially their authority. And again, even though we had evidence that in 10,000 trials, there was not a single complication from these women giving injections. So again, I'm a big fan of hard evidence and randomized controlled trials, but when you compare hard evidence with vested interests, guess who wins that argument? Okay? So winners and losers is very important. Is it implementable in new contexts and to new beneficiaries? Okay, so we talked about the importance of context, and if context changes, how easy is it to transfer? So this is a big question if you're moving from an NGO system to a government delivery system at scale, right? I would characterize most of the NGOs that I know in India as mission-driven, values-based, bottom-up, grassroots, participatory. Does that sound reasonable? Okay. Would you use those same words to describe the public health system? Grassroots, bottom-up, participatory, experiential. So if you think that the values, okay, that were used at small scale, or the organizational culture, was important to delivering the model, and those values are different in your large-scale implementer, then you have a problem. Does that make sense? Okay. And last but not least, is it testable or affordable? Is it cost-effective, and does it fit within the budget constraint? Okay. So let's apply this to the HB&C model. Well, it had solid evidence. It, as I said, had internal validity. Was published in The Lancet. Abe and Ronnie Bang, who are the two people, the co-directors of Search, are internationally famous. They were named International Health Heroes by Time Magazine. There's, in terms of observability and emotional appeal, Saving Newborn Lives is a pretty good one, and it's pretty tangible. Their ashram is Gandhian. People who visit it love it because they see people who are stopping every day for 2 hours and collectively cleaning. They live collectively, very simple, vegetarian, it's not a fancy place. And also they were able to mobilize a lot of prominent doctors at Ames and other places to support this. So in terms of credibility and observability, HB&C was pretty good. Was it relevant? Well, bringing down the infant mortality rate was a huge policy objective. It was particularly one of the MDGs. But interestingly enough, it wasn't that important to beneficiaries. And that, in some cases, proved to be a problem because people took as normal that babies died. Okay, so that's a question. And there was no proven alternative, but there was an alternative called IMCI, which is Integrated Management of Child Illness, which was being advocated at the time by UNICEF. Okay. So who were the winners and losers? Well, I already talked about the Indian Medical Association, but UNICEF was extremely upset because they didn't like this model because it was a grassroots model. And what was IMCI? Anybody know IMCI? It was an institution-based model. So if any of you know anything about public health, and particularly maternal and child health, there's been about a 50-year running battle, maybe not 50, 40, between people who think that the solution is that everybody should get hospital care, and then people say, well, we've been waiting for 40 years for you to build hospitals in rural areas. You never build them, so we need rural medical delivery. And then the institutional people say, but if you get that, then you'll undermine the need for the hospitals. So they go back and forth. About every 10 years, the pendulum swings. So all the advocates of institutional care, which included UNICEF, were opposed to this model because they felt it would threaten the building of more hospitals and clinics. Okay? Notice how evidence-based this is. Okay? And then there was a question, was it too complicated? Was it too high quality? Was it too supervision intensive? So what I didn't mention, but it's in one of the earlier slides, is that the training for the VHWs was 6 months of training. Okay? It was 6 weeks of classroom training in each module, followed by 3 weeks of field practice. It was very community-based, and everybody said, well, it's one thing for this really good NGO to do it, but could the government do it? And was it affordable? Okay? Now, fortunately, at this point, the government of India was actually giving a huge amount of money to rural health through the National Rural Health Mission, and actually the money wasn't being sent by states. So I think the common complaint that there's not enough money for scaling up is a false one these days, especially in India. At least in a lot of social sectors, the government has money, the states get the money, and they can't spend it. Okay? So I think this question of affordability or budget constraints is less of a consideration. So we then decided, how are we going to improve the scalability of this? And we considered simplifying the model by shortening the training, decreasing the supervision. We also documented the processes and the tacit components, like the importance of empowering the women. And we decided to try to get as many neonatologists and pediatricians to support the model to counterbalance the opposition of some of the Indian Medical Association. We also decided to prove external validity by testing it in other locations and delivering it by both the NGOs and the government system, so that the criticism that it was only an NGO-based model could do it. And these were other sites in which it was implemented around the state of Maharashtra, which included urban slums and tribal areas, as well as the rural area in Gadchiroli, which was all the way out here in the eastern end of Maharashtra. And you can see that even in the Anchor model, the comparison of the baseline and the intervention was quite a significant drop. Okay? So the next part of our scaling up strategy is to figure out who's going to do what. Right? We've figured out what the model is, and we figure out where we want to scale it up. Now we have to figure out who's going to adopt it. When I say adopt, I'm using the word of give permission to do it. Who's going to manage it? Who's going to implement it? Who's going to resource it? And who's going to monitor it? Now, I've separated out these functions as if they all have to be different organizations, but they could all be one organization. It could all be the public health system. The government Ministry for Health and Family Welfare says, we like this, we're going to do it, we'll manage it. Our frontline primary health clinics, our nurses, doctors, A&Ms will implement it, we'll pay for it, and in principle at least, we'll monitor it. The government isn't usually very good at monitoring at scale, but that's a separate conversation. Or they could all be different. Okay? And there are three choices in how you scale up. One is expansion, which is the existing organization grows. That's the balloon. Or you could think about, we call this in the States, I don't know what you call it here, a spider plant, where you send out shoots. So for those of you who are implementing through NGOs like Catholic Relief Services, could, for example, grow its own activities. We had an initial grant for $1 million to do 2 districts. Now we're going to expand our own, notice the word I use, capacity to do 5 districts. We're scaling up by expanding our own organization. Okay, that's one choice. Second choice is what I call replication, which is we give it to somebody else. Okay, we did it in an NGO, but we're going to either give it to a bunch of other NGOs or we're going to give it to the government. Okay, we're solving the capacity problem by leveraging existing capacity of other organizations. Right? Expansion is you build the capacity. You presumably have the capability, you build the capacity. Replication is the opposite. The capacity exists, and you're going to build the capability in those other organizations. Does that make sense? Okay. And then the third option is somewhere in the middle, which I call collaboration. And collaboration can be done a lot of different ways. One is, for example, you can get a lot of organizations to work together that can do this in lots of different places. So it's a mixture of they have the capacity and you build the capability, but it's not one organization doing it, it's a bunch of them. Or you could do it by task, right? So for example, let's say if we come back to the iron folic acid model, and that has basically 2 components, or 3 components. One is delivering the stuff, and the other is teaching healthcare providers and parents how to use it. Okay? We could say, well, we'll have 2 organizations do it. One will do the supply chain, and one will do the training and community sensitization, because we can't find an organization that does both well. Okay? So you can think of lots of mixes and matches and do this, and they could be private sector, public sector. Okay? So what's the advantages, or I'll ask the rhetorical question, what's the best way to scale up? Is it expansion or replication or collaboration? Anybody ever take economics? No matter what the question, in an economics class, there's only one answer. That was always right. Do you know what that was? It depends. Right. So, what does it depend on? Well, let's look at expansion first. Okay. When is it more important, do you think, to have capability and build capacity versus to have capacity and build capability? What does that depend on? Yeah, Mahumita.
When it's not a very complex task.
Right. Well, let me flesh that out, but you've hit the nail on the head. Okay. If I'm giving people injections, let's say somebody invents an HIV vaccine, is that a model where doing it right, where the tacit knowledge, the quality, the process, the values are very important? What would you say?
Yeah.
Giving an injection? No. Okay. As opposed to empowering teenage girls, do we use the expression sugar daddies here? Yeah. Okay. To say no to sugar daddies. Okay. Is that the same as giving an injection, or is how you do it and how you empower those girls to be able to say no more difficult? Okay. In which case would the culture of the organization make a bigger difference? The injections or saying no to sugar daddies? The saying no. Okay. So if you use expansion, you already know that you have the right culture and you're building capacity, right? So expansion would make more sense for the saying no, right? Replication would make some more sense for the injections. Does that make sense? Okay. And a slight variation on that is getting it right versus adaptability. Okay. So what if it turns out, I'm not sure we can use the same model or the same example, that because of a difference in culture, as we move from Maharashtra to Gujarat to Rajasthan to Uttarakhand to UP, okay, the context of gender and young girls changes a lot. Would you want to expand the same organization into those different places? Or is local knowledge going to be important? Right? So in that case, we would think that replication and collaboration might be important. Okay? Now, of course, what gets tricky is when culture is important and local knowledge is important, what do you do? Right? Do you understand that there are trade-offs, so there's no right answer here? Am I making this too complicated, or is everybody following me? Yeah, you're with me. Okay. And what about advocacy and marketing? Okay. If I give somebody a shot and they don't get sick, is that easy to see? Yeah. Okay. So is that easy to sell? Okay. So if we have to sell, which involves more selling, replication or expansion? Expansion, you're doing it yourself. So the only people you have to convince is you. Now that may not necessarily be straightforward, because I cannot tell you how many NGOs I've worked with that the leadership wanted to scale up, and either the board of directors didn't, or the funders didn't, or the staff didn't. So even expansion requires some internal advocacy and marketing, but it's different than external selling, okay, where you have to go out and convince other people. So it's often easier to scale up things where the results are tangible and visible through replication than it is through expansion, and vice versa. Okay? And finally, we've sort of talked about this, but incentives and organizational culture. Okay? So if incentive, like, how many people are actually familiar with some of the JPAL models? Okay? So if you haven't read some of the really great studies, one of the things they're very big on is incentives, like how do you reduce absenteeism? And they've used, for example, time and date stamp cameras where an A&M doesn't get paid if she doesn't show up at the vaccination camp on time. Okay? Now you can think what you like about that, but there might be some organizations where they would be very willing to adopt that kind of an approach. Do you think the public health system would adopt date and time stamp campers and fire and not pay A&Ms if they don't show up on time? Okay, so again, are the incentives compatible with replication or collaboration versus incentives? Now notice the problem, right? We only have 3 choices of ways to do it, and we have all these different considerations. Okay, so that's why scaling up is hard, because there's no perfect answer. There are all these trade-offs. All right, so I think what I want to get to is this, because I'm starting to run out of time. Okay, is we have to choose the what. Whoops. Boy, that was really good, Richard. Hang on a second. Let me fix this without my glasses. All right. So I want to go back here. So the model is the what, remember. The where is the goal, and this is the how and the who. And we can fix the how and the who by doing either capability or capacity building, right? Except it says no. Okay? Does that make sense? You with me? So what happens if we have a model that will achieve the goal one, let's say reduce infant mortality by 75%. We want to go to 500,000 villages, and we decide to go through the government public health system. Okay? Except we don't think that the government public health system has the capability to implement it with sufficient quality to achieve a 75% reduction. Okay? So the pieces don't fit together. What do we do? Well, we have a lot of choices. One choice, the easy way out is we change the goal. We say we just don't think the government's going to get there, so we're going to expect a 35% drop instead of a 75% drop. That's kind of the easy way out, right? Or we could try to do capability building. We could try to improve the effectiveness and A&Ms, and does everybody know what ASHAs are? Yeah, the ASHAs are relatively new. They've been around for a few years now, which are basically village health workers. Okay, so we could try to improve the capability, or we could simplify the model to align it with the capabilities that exist, though that probably also would imply a decrease in the impact. Okay, so we could change the goal, or we could say we're not going to scale up through the government. We're going to contract out to a bunch of NGOs or the private sector to deliver this model instead of the public health system. Okay, where would that get us? What do you think about that solution? Could you say louder?
Sustainability.
Well, the government's going to pay for it. They just don't want to pay for it through their system. Okay. Think we could reach the same scale? You think we could find enough NGOs to reach 500,000 villages in India? Okay, I've actually done this research. You know what you can reach with NGOs in this country? About 5 to 10% of the population. Okay. So my point being that if we change the who, we could stick, because they have the capabilities, we lose the capacity, and therefore we don't lose the impact, we lose the scale. So I actually spent a whole year arguing with the leadership of Search, which is better, covering 75% of India with 35% impact, or 25% of India with 75% impact. Okay? And the short answer was we ended up going through the government. But it took a year to convince them that getting lots of people something was better than getting a few people a lot. Okay? And so, in fact, that's the trade-offs here. Okay? So I've only got a few minutes left. It was interesting, by the way, because one of the things that was a big challenge with Search is they refused to simplify the model because they believed that quality was more important than quantity. Okay? I'm not going to tell you what the right answer is to that question, but I'm going to tell you that if you think you can have both at scaling up, you're most of the time fooling yourself. There is no perfect world. And so one of the biggest challenges in scaling up is how to make those trade-offs. And what I urge you to do, and this is where it links to the evaluation, is get as much information as possible about if we cut or dilute this particular element or component of our model, what impact will that have on cost? Because I can guarantee you go to the government, the first thing they're going to say, costs too much. You have to cut it by 50%. It's too training intensive. We can't give 8 days of training. We can only give 4 days of training, et cetera, et cetera, et cetera. Okay? And you need to be able to come back with the evidence that shows, okay, if we're going to go from 1,000 rupees to 500 rupees per beneficiary, which ones do we choose? Okay? So since I only have a few more minutes, I'm going to just close with a few lessons and then open it up for questions and answers. Okay? So in the case of Search and HbA1c, remember I talked about you can't scale up a solution if you don't have, if the problem was very important. So we were saved that problem. IMR, infant mortality rate, was an MDG. So one of the things you do want to think about, though, is are we trying to scale up something for which there is huge popular demand and policy demand for it? If it's not, then you need to work on advocating for the problem and not just the solution. And I like things like the White Ribbon Alliance because those create political sustainability, right? White Ribbon Alliance isn't the BJP organization, it's not a Congress organization. It's a national, for those of you who don't know, it's a national network of NGOs that advocate for maternal health issues, and they are there no matter who's in government and which donor is funding what, because we want long-term political sustainability, okay? So we also found an NGO coalition and evidence and expert champions were initially too weak, but with time, we were able to develop a third advocate or expert champion that actually allowed this to be scaled up. Does anybody know who that turned out to be? All health experts. Does everybody know what NHSRC is? So basically, the government realized that the health system was broken. They created the National, what does that stand for? National Health System Resource Center. And they became advocates for this model and for training ASHAs adequately to deliver the model. So kind of got lucky. We got lucky twice because we got lucky that the government was creating ASHAs in the first place, and we got lucky because an institution got created that basically was advocating for quality ASHAs, which was NHSRC. Okay? But if you don't have an NHSRC, then who's going to do this? How many of the government sectors in India have an equivalent of NHSRC, of a capacity building organization committed to improving the quality of the system? Yeah? Okay? Need to compromise on goals, impact, and method. So we've talked a lot about that. Going to scale takes time. Okay? This model was originated in 1990. We started advocating for scale up in about 2006. It started going to scale in 2011, and it's still not. It's only now finally being implemented at scale in 2013. So think of the time frame there. Okay. So I know there are a few of you from USAID here, and I don't want to scare you, but I was once at a workshop in Washington D.C. and several members of the House Foreign Aid Appropriations Committee were there, and I said, you know, a lot of USAID-funded projects don't go to scale. What do you think we can do about that? And the congressman said, nothing. And I said, excuse me? He said, well, look, we're on a 2-year cycle. I run for office every 2 years. So I want the administrator to come to me and show how many schools, hospitals, clinics, teachers were trained. This has a longer time horizon, and it doesn't match the time horizon of the political cycle in the US, or maybe not in India. So one of the key questions you have to figure out is how to set intermediate goals to match the political process. I hope you're taking away from this, because I haven't made it explicit. We're going to make it explicit now. Scaling up is as much about a political process as it is about a technical solution. Okay, this is not engineering, right? It isn't, you know, here's the solution. And a lot of people think that. I actually worked on scaling up something called, what was it called? The non-pneumatic anti-shock garment in Nigeria. The non-pneumatic anti-shock garment is basically, looks like a wetsuit. It's neoprene, and you cut it in pieces, and when a woman goes into hemorrhage when she gives birth, you wrap it around her lower body, and it stops her from bleeding to death until she can get to a clinic where they can treat her. Okay? Was very successful in trials. Actually, it was approved by the FDA for other U.S. Food and Drug Administration a long time ago. Very successful in Nigeria in stopping hemorrhaging and treating. And the MacArthur Foundation was funding it. The president of the MacArthur Foundation wanted to scale it up, and you know how he wanted to do it? He was willing to buy 200,000 of the garments and ship them to Nigeria. No training, no advocacy, no community sensitization. Just drop them from helicopters. He wasn't going to drop them from helicopters, but you get my point. Okay? That, remember I talked about at the beginning of the talk the importance of documenting the process, the getting ownership, buy-in, all the incentives, all that kind of stuff. So why would a doctor use this? Okay? And you know what proved to be the stickiest problem in scaling this up? Who was going to clean it? Because the doctors wouldn't clean it. Okay? Because they don't do that kind of work. And they were being paid extra. So documenting all those processes and all those incentives are important. It's harder to scale up community-based, value-driven programs into a bureaucratic bureaucratic, medicalized system. So that's the tension I was trying to point out to begin with, that there tend to be different values and different organizational cultures as we move from NGOs to private sector to government. None of them are right or better. Well, you may have your opinions on that, but I'm going to be neutral on that, okay? But my point is that if you pilot something in one system, you better be sure that its success is not peculiar to that system. Because otherwise, if it is, you need to scale it up within that system. And then you have those constraints. Or the other point I'll just make, again, I don't mean to pick on USAID because I love USAID. They've paid my salary indirectly for many years, so I owe them a lot. But there's a tendency in a lot of donor-driven projects to be solution-driven. In other words, no matter if we can get a really good chief of party, we will fix this, right? Okay. Well, then you're not proving that the innovation works. You're proving if you hire five really smart people who are expats from the US or India or wherever, who all have PhDs from Oxford or Harvard, they can do anything. With, give them $5 million in 2 years, they will reduce, infant mortality among 200,000 people. But is that scalable? Because in order to scale up that model, you have to have that same quality chief of party in every place you go. And I don't think that works. Okay? So especially if you're a donor, you want to make sure, what does scale mean? Anybody take statistics? Right? When you go to scale, it means average. Right? So if it's a small NGO with dynamic, charismatic, hardworking, highly educated, very intelligent people, that works great in 3 blocks. It doesn't work great in 3 states. Yeah? Same thing with a donor project with a really good chief of party and a deputy chief of party and a project manager and M&E evaluator. That's great for the project, but do those quality of people exist at scale? By definition, there's a radio program in the United States. It's a comedy program, and the host of the program, there's a make-believe place called Lake Wobegon. And in Lake Wobegon, all the children are above average. Okay? Well, in scaling up, we like to think that all the delivery people are above average, but that's a contradiction, right? Not everybody can be above average. So how do we ensure that we deliver this? This can be delivered by average people, okay? And I think the last slide I'm going to leave you with is this one, okay? So this is we've seen this before. This is the sequence. There's a promising innovation. We demonstrate internal validity. If we're lucky, we demonstrate external validity in terms of organizations and places. We do some dissemination and advocacy. It gets adopted into strategies. Does that sound familiar? Yeah? Part of the government's policy and maybe even programs, maybe even funding, and maybe we even get it to the front line. Then we do capability and capacity building. We implement at large scale, and we ensure impact by monitoring outcomes at large scale. Right? This is what scaling up takes. A lot of organizations stop somewhere between here and here. We fund the project, we show the evidence that it works, we hold a workshop, we publish the nice 5-page glossy with the pictures. You like the 5-page glossies or the 10-page glossies? And maybe we do enough advocacy to get it into policies. What happened there? Policies and programs. There we go. Okay? Or even funding. We don't usually get to the funding part. Well, who does the rest? Especially in a country like India, just because the government in Delhi adopts it, doesn't mean anything that the state of Rajasthan or Bihar or Jharkhand or Punjab or Orissa have adopted it. And we all know that all those state secretaries up there have a very different agenda. Doesn't mean anything about the districts in the front line. This is not communist China, right? Just because a letter comes from the state secretary in Delhi and goes all the way to the line doesn't mean everybody jumps. I can't tell you how many times I've been looking at a scaling up case. I go to some rural district and I say, so, are you implementing this program? Oh yes, we got the letter. And they show you the letter. They're not doing anything, but they have the letter. Okay, so if you think if you want to stop at the letter, if you think the letter helps people, you do that. But otherwise, you need to figure out if your mandate stops at 4 or 5, who's going to do 5, 6, and 7, and 8? And I think for a lot of organizations, this is the big challenge, is how to find partners to make sure that the entire 1 through 8 gets done. Okay? The one tip I'll give you is that a lot of organizations say, well, we don't have the money or the capability or the capacity to do this stuff. 5, 6, and 7, which is fair. Okay. But you often do have the money for 8. You may not have the money to train 500,000 OSHAs. Okay. But you might have the money to fund an evaluation of what the 500,000 OSHAs are doing. Right? Or the capability. And I think one of the places where in a lot of countries the system is weak is that, remember what happens along the way here is we get dilution of quality and fidelity because this step doesn't get done. And so NGOs, donors, and a lot of the people in the room can help, if you're going through the government, this happen by having external monitoring at the end. Or the other solution is contracting out, or public-private partnerships, which solve some of these problems too. And they all have those pluses and minuses, right? So for the reasons we talked about. So to sum up, identify the model's intangibles, the process, the preconditions, define clear goals, where, what, who, and what impact, not just scale, but scale with what impact. The external factors that will affect it if you move from one place to another or one organization to another. Start with the end in mind and work backwards. So if you're going to pilot something that you want to go to scale, but there's no large-scale organization that has the culture or the capability to do it, is it really a scalable model? Right? And similarly, what kind of money is that going to take? Oh, yeah, it's $1,000. You know, I remember I was asked to evaluate the scalability of a USAID-funded program, in Rwanda, which cost $3,000 per beneficiary. And the midterm evaluation said it was a really good program and potentially scalable because on average similar programs were costing $6,000 per beneficiary in other countries. I thought to myself, well, in Rwanda the per capita GDP was like $600. The government is really going to take on a $3,000 per beneficiary program at scale when the scale that we're talking about was something like 1 million people? Okay, so do the math. 1 million times $3,000 was $3 billion. This was on a girls' empowerment program. Hard to imagine. So do the financing and the unit costs fit within the feasible budget envelope? And are there sufficient organizational resources? Who's going to do the going to scale? Who's going to do all of this stuff? Because if one of these things doesn't get done, then it's like running a relay race, except there's somebody missing in the relay. Okay? So I think we do have time for a few minutes of questions. Yeah. I think they want you to use the mic so that they are taping this.
Sorry, Richard, I go back to my original question that I asked the other day. And that is, if you only have the capacity to take it up to number 4 of the other chart, up to a certain level, at what point do you get your potential partners that's going to take it to scale involved? Because it's got to be a buy-in from them.
Right.
So what is that stage?
Well, I think it's here. I don't think it's at 1. Whoops. Because I think 1 may be too early. Because I think we kind of want to leave to the technical experts. Like, how do we know this thing works at all? Anywhere. But I think once we get to 2 and 3, then you want their buy-in. Right? We're picking. We should start to be thinking, once we get something that we know works somewhere by somebody, we're starting to think, okay, at scale, who would do this? So why would you, if the scale you want to reach is sufficiently large that only the government can do it, why would you want to test it in NGOs? Unless you think you could persuade the government to contract out to NGOs to deliver it, which is fine. That's a viable alternative. Or to the private sector. But then you need that buy-in. Right? You need that buy-in when you're creating internal and particularly external validity. Okay? Because I cannot tell you the number of times I've heard, it's only in the last 5 or 10 years, which, in India is a very old country, that NGOs and the government have been more and more working together in partnership. But it used to be a very adversarial relationship, which is basically, the NGOs were always running PILs, in the Supreme Court because you're not doing this and you're not doing that, and the government was always on the defensive. So why would I adopt an innovation from somebody who is suing me in court with a PIL for something I'm not doing, 2 days ago? So building those relationships early on, I think, is quite critical. And there's lots of different ways you can do it. But, we didn't really talk about it, but that's the advocacy portion of this, is getting that buy-in as early as possible. One of the things we also didn't talk about, but for me is quite key, is it's, depending upon the intervention, it's not always obvious who the right organization is. And I've worked a lot on agricultural and rural poverty interventions. Well, historically, people used to think, it was the silver bullet. It was the right kind of corn seed or the right kind of cow that produces more milk and yada, yada. But increasingly, there is a growing emphasis that, transforming rural poverty is a social problem. It's creating self-help groups. It's creating farmer cooperatives. It's empowering women farmers, all that kind of stuff. Well, in a lot of countries I've worked at, the equivalent of the Ministry of Tribal Affairs is often better at doing social agriculture because all the are veterinarians and agronomists, and all the tribal affairs are social welfare workers, social workers, and people with rural development backgrounds. So starting to think in advance about who do you want to align yourself with, who's got a champion, who's got budget authority, who has the right organizational culture, may be the right way to go. So I say you do it after you know that it works somewhere, and once you start to get into sort of the pilot stage for internal validity and external validity, is the short answer, or not so short answer. Other questions? Yeah, please.
Hi, my name is Niti. When we were talking about scalability assessment, you mentioned one of the things is being observable, one of the indicators. Now, you gave the example of an empowered woman, that it's difficult to spot an empowered woman. So my concern, it's not a question, it's a concern, that when we talk of scale up, then the question that we need to, the choice that we need to make is between the tangibles and the intangibles. Now, an empowered woman basically comes into the intangibles, but and social behavioral changes, which are very essential for sustainability of any intervention. So, what do we do about it? Do we overlook the intangibles when we are talking about a scale up, or what do we do?
Well, the reason I said all that was not to I hope nobody is going to come away with the conclusion that anything that's a social change that's difficult to observe or intangible, therefore we shouldn't scale it up. Because I'm personally of the opinion that most of the things that, well, we live in a world civilization that's obsessed with technical solutions to social problems. And I'm sure there are some. And if you want to get grant money these days, or donor money, all you have to do is either say it's an M project or an E project, and this is M Health or M Education or something like that, and you get more money whether it works or not. But a lot of these problems are social problems, and they require social solutions, and therefore the intangibles in the process are important. I guess my solution to that is to be more creative and innovative first of all, to be aware that it's going to be a challenge. That's the point I was trying to get across, and to be more innovative about it. So, for example, videotaping. It's hard to walk into a village and see 10 empowered women, but it's not so difficult to listen to a 15 or 20-minute short film in which a woman talks about what her life was like before she did this program and afterwards, and now her husband doesn't beat her, she's able to spend money on her own, she went back to school, or she was forced to drop out of school at the 6th standard, but now her daughters are completing the 12th standard, etc., etc. That kind of personal testimony can often be very powerful. So I guess when you're talking about qualitative impact, then you need to have qualitative evidence. And I think that there's such a focus on quantitative evidence that we tend to lose stuff. So we could talk about this for a long time, but that's the short answer. Somebody else? Yeah.
When you talk about scalability, we talk about grants, and we talked about converting them into national programs where the government starts supporting them.
but there's a time gap, between the grant phase and the scaling up phase. So, and there's a new concept of social impact funds coming up these days. We see a lot of them in the social impact space. So, what do you think is the role of those social impact funds and the private sector in scaling up?
Oh, I teach courses on social enterprises, so I'm a big fan of social enterprises because, this is a complicated question, and it's a case by case and country by country. In India, for example, the Constitution, and I think a lot of the public really feels like it's a public responsibility to address these things. And so, I think at least among the left, there's some hostility to getting the private sector involved because I think the private sector is perceived as evil. And it's a way of the public sector shirking the responsibility. Now that's a cultural and political question that I can't address because I'm not Indian, okay? But certainly in countries where the private sector is considered more acceptable, such as the United States, which maybe thinks it's too acceptable, I think we think the private sector is a solution to everything, social enterprises are being very effective. I think one of the things we didn't really talk about, just because I couldn't talk about everything in an hour, is co-funding mechanisms. So for example, a lot of the social enterprises that I work with in the United States cross-subsidize. They sell meals or they sell training or education or healthcare services to a certain segment of the population, and they use that to provide it for free or for low cost to other parts of the population. They have some activities that they make money on and some activities they provide for free. So I think whether it's social impact funds or social enterprises, I think they're very viable solutions. But you have to have a culture that supports that, and I think I'm not Indian, but my sense is that in India that's still very much a work in progress. And I also think, let me just say one other thing, is that it's not just a change in the mentality of the left or civil society, but it's also a change in the mentality of the private sector, because I think historically the private sector here has had a very much seen its social responsibilities as charity. If there's one, there must be 5 million eye clinics in this country. Everybody wants to go out for 2 days and do cataract surgery. Well, that's nice for the things that you can fix in 2 days, but a lot of social problems you just can't send a doctor out to the rural sector for a day and solve the problem. It really takes a much more substantial impact than that. It takes more than charity. It takes empowerment and capacity building, and I think that if the private sector wants to play a role through social enterprises, social impact funds, and they have to recognize that the charity model, which may have worked 50 or 100 years ago, is not. So there needs to be a change in mentality on both sides. But I'm very sympathetic, and I think it's a very viable model.
So, Richard, I think in the interest of time, we're going to take our coffee break now. But I'm glad that we have a lot of questions that are starting to arise. This afternoon, after we take our quick coffee break, there'll be the opportunity to see some live coaching sessions. So a few of the organizations are actually going to talk through some of their plans to scale up particular programs. And that is also a really excellent opportunity to raise some more of the questions that you might be thinking, and to be able to see how some of the ideas can actually be put into practice. So let's take a 10-minute break for coffee and tea. I'm going to also draw your attention to a feedback form that's in your clear packets. So if you can take the time to fill that out at some point before you leave this afternoon, that would be fantastic. And if we can all be back in this room in about 10 minutes, then we can get started for afternoon session.
If it wasn't clear what Mara just said, I thought it might be the most, I don't know if educational is the right word, but the best learning opportunity to actually see live my work with a few organizations in terms of designing a scaling up strategy. So I'm going to work with 3 organizations for about 20 minutes each. Now, usually I spend 3 to 6 days with an organization to do this. So if you think we're going to answer all the questions in 20 minutes, I don't want you to have false expectations. But I think a lot of the questions which I've tried to address in a broad structure will come up in specific, and hopefully that will be a good learning experience. If you want to leave now, after the coffee break, please feel free. If you think that would be a valuable experience for you to stay, you're obviously welcome to stay.
Thank you.